Good morning, and today's lecture is going to be on Chapter 24, which is nursing care of patients with occlusive cardiovascular disorders. So what we're talking about basically is CAD, coronary artery disease. What are the learning outcomes for this chapter? You're going to be able to explain the etiologies, the signs, the symptoms, and whatever therapeutic measures we put in place to deal with coronary artery disease, angina pectoris, which is angina, and MI, myocardial infarction, which is a heart attack. We're going to list the data that you need to collect when you're dealing with these disease processes. And we're going to describe therapeutic measures that we use to treat those diseases. And also we'll talk about peripheral vascular disease and nursing care of those patients. If you look at the fourth slide, you will see an actual picture of a cardiac cath. That's on the left. And on the right is a drawing that makes it a little bit more clear. But when you look at that picture, so when we do a cardiac catheterization, typically what we're looking for is occlusion or blockage in one of the coronary arteries. It's one of the arteries that feeds oxygenated blood to the myocardium, the muscle of the heart. So if you look at that picture of the cardiac catheterization, you can see where the catheter is inserted, and then you can see where there's an occlusion. So we need to do something about that occlusion. Why is there an occlusion? Well, typically it can be either atherosclerosis or arteriosclerosis. Those are two of the reasons. Arteriosclerosis, people call it hardening of the arteries, if you've ever heard old people say that. What happens is the walls of the arteries and the arterioles, which are the tiny little arteries, can get thicker. They can lose elasticity. They can start to calcify. And this happens with age. Other people, not me. And when they get hard and stiff, then the blood can't get through as it used to, right? That makes sense? Now, atherosclerosis is the formation of plaque in the arteries. And this is typically because of things like high cholesterol, high triglycerides, right? Lipids, fats, okay? This can actually start in childhood and can progress to coronary artery disease as the person ages. So, when we say you are what you eat, we're not kidding. So when we talk about risk factors, modifiable, non-modifiable, things that you cannot change, non-modifiable. You can't change your age. You can't change your gender. Not really. You can, but not. Your DNA is still either male or female. You cannot change your ethnicity, your genetics, right? Those are things that you can't change. Modifiable risk factors, that's a much longer list. Control your blood sugars. Control hypertension. Control hyperlipidemia. If you're obese, lose weight. Quit smoking. Other people, not me. If you lead a sedentary lifestyle, you need to get up and move, okay? Excessive alcohol intake, cut down on alcohol. Depression and anxiety, believe it or not, are risk factors that are modifiable. We all have stress. And so what do we do to manage that stress? There are ways to do that where it doesn't affect you physically, physiologically. When you're stressed out, all of your arteries, all your blood vessels get stiff and tight. And that can actually, over the long term, cause coronary artery disease, okay? And believe it or not, infection. So certain types of infection can cause coronary artery disease. We'll talk a little bit more about that later. How do we test for it? Well, lab tests, we're looking at total cholesterol, which should be under 200. We're looking at LDL and HDL. LDL is low density lipoprotein, that is the bad cholesterol, should be 100 or less. High density lipoprotein, remember that because H stands for healthy, that's the good cholesterol, and that should be 60 or higher. So HDL, higher is better. LDL, lower is better. And then your serum triglycerides, in other words, how much fat is in your blood, that should be under 100. The higher that is, the higher your risk is. So what do? Again, back to food. I can't emphasize this enough. Heart-healthy diet. Limit your trans and saturated fats, okay? Don't smoke. Exercise. And now here we're talking about cardiovascular exercise. Bicycling, spinning, swimming, running, aerobics. To make it very plain and simple, you have got to break a sweat. And you've got to do it several times a week. If you never break a sweat, and never raise your heart rate and get your heart pumping and your blood flowing, you are increasing your risk for heart disease. And then if all else fails, there are things we can do like, statins, lipid lowering drugs, okay? With coronary artery disease, there is an obstruction of blood flow, like I said earlier, atherosclerosis, arteriosclerosis, and when the blood flow to the myocardium is restricted or reduced, that causes angina, which is chest pain. Can also cause MI, myocardial infarction or heart attack. Can also cause sudden death. Boom. Okay. So, always we want to prevent. It's easier to prevent than it is to treat anything. So prevention, low cholesterol, low saturated fat, lipid lowering agents. Watch that blood pressure. Remember, silent killer. No symptoms. Okay? Watch that blood pressure. Make sure that blood sugars, because I can't say this enough. Type 2 diabetes, which we're going to get to endocrine today. Type 2 diabetes is the #1 risk factor for cardiovascular disease, in addition to that things that are modifiable like diet and exercise. So you really have to keep blood sugars, within normal limits. And we'll talk more about what those numbers actually mean later. And of course, smoking is not good for you. So with symptoms, what are we talking about? Symptoms of ischemia. Ischemia, the word means lack of oxygenated blood flow. Chest pain, right? But not everyone gets chest pain. There can be vasospasms, right? Spasms of the heart. Valvular heart disease, believe it or not, if a mitral valve or aortic valve is damaged in any way, that can be contributory factors with angina, and heart failure and hypertension are also contributory factors. Understand this, that your body is all working together. Every body system works together to make homeostasis, if you've never heard that word before. Homeostasis means that your body is all working together. Everything is aligned, all the body systems, for your metabolism and for all your systems to be working the way they were meant to work. Any one factor will affect others. It's like a domino effect, right? So make sure that you understand that. So with angina again is caused by coronary artery disease and the narrowed blood vessels. Blood can't get through. Less blood, less oxygen to the heart muscle, less oxygen, ischemia. Ischemia causes necrosis. Necrosis is death of tissue due to lack of oxygen, and it's very painful. I'm not going to get into the types of angina, but just understand that, stable angina is, people that do a little bit of moderate exertion, like the little old lady. She doesn't have chest pain until she vacuums. So that's moderate exertion, and that's when she starts to feel it, because she's increasing her heart rate and her myocardium isn't getting enough blood flow to fulfill the demand, right? But the pain's very predictable, right? Unstable angina, that's unpredictable. So it can happen at rest. It can happen when people are sleeping. It can happen anytime. Usually not relieved with nitro, where the stable angina usually will be relieved with nitroglycerin. Okay, so make sure that you know that. We talked about the signs and symptoms. It can be pain, but it doesn't have to be pain. Heaviness, tightness, a crushing feeling in the chest, feeling like someone's sitting on your chest. Sometimes the pain is what we call referred pain. It can radiate. Can radiate to the arms, and it doesn't have to be the left arm, either one. It can radiate to the shoulders, the neck, the back, the jaw, any of those places. The patient's going to look pale, they're going to look diaphoretic, sweaty, and they're going to be short of breath, dyspneic, okay? With women, I want to make sure that you realize this, women will have atypical symptoms. In other words, symptoms that aren't the ones that usually men will complain of. Men will, this is the big one. That's it, I'm going. Chest pain. Women can have something subtle, like indigestion and heartburn, that persists for a couple of days, fatigue, nausea, a little bit of breathlessness or dyspnea, and women will ignore those symptoms. And then the next thing you know, they'll die because they've not address the symptoms. Heartburn, it'll take some Tums and it'll go away. When heartburn or indigestion persists for days, you need to see your doctor because there's something going on, right? What do we do to diagnose? Well, EKG, ECG, electrocardiogram, and exercise. electrocardiogram, which is a stress test where they go on the treadmill, right? Echocardiogram, ultrasound of the heart. There's such a thing as a chemical stress test, and I'll point this out real quickly. So for people that have things like really severe osteoarthritis or any other disease that would preclude them from being able to get onto a treadmill and either walk fast or run or jog, we can actually infuse in an IV chemicals that will increase the heart rate so it simulates exercise, but they don't even have to move, right? So if somebody's got, say, bad knees because they're 70 years old, they don't have to run on the treadmill. We can do a chemically induced stress test. We can do a CT scan. We can do cardiac magnetic resonance imaging, also known as an angiogram, MRA. And then we can, of course, do a cardiac catheterization, which is coronary angiography. So what are the goals? We want to make sure that we know what the risk factors are. And then the therapeutic interventions, and I can't say this enough, and yes, I'm repeating myself, and no, I don't have Alzheimer's. Lose weight, eat right, reduce stress, relieve the pain, medications like nitro, and then also calcium channel blockers like amlodipine are used. Beta blockers sometimes, the laugh out louds. Angiotensin converting enzyme inhibitors, your ACEs, which are your prils, captopril, lisinopril, enalapril, ramipril. Statin drugs to lower lipids, and then antiplatelet aggregators, which are your aspirin and your clopidogrel products. Okay. Then the next slide has some nursing diagnoses. Make sure that you remember something. Slide 23, I put in there MONA. When you think about angina, severe angina, MONA, 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 MONA. MONA stands for morphine, oxygen, nitro, aspirin. So we love acronyms in the medical field. Remember, the first nursing intervention, if I'm complaining of chest pain or anything that looks like chest pain, get the oxygen on me. Morphine to relieve the pain, nitro will vasodilate, aspirin to prevent a clot from forming. Okay? MONA, MONA, MONA. All right? The next page goes through the nursing care with regard to the nursing diagnoses. Please read through that. There's such a thing as cardiac ischemia, silent ischemia. And silent ischemia, what that means is there's no chest pain, a silent heart attack. Usually with older patients that have hypertension or diabetes or both, they will not have the classic symptoms. They won't have any chest pain. They won't have any pain at all sometimes. And then the next thing you know, boom, and they keel over. That's a silent MI. And then, when that happens and there's sudden cardiac death without kind of any warning, it's usually, typically triggered by a lethal ventricular arrhythmia. In other words, ventricular tachycardia that leads to ventricular fibrillation. With both of those, the patient will be pulseless, okay? And we need to defibrillate them immediately to prevent them from dying. Okay. What is an MI? An MI is a myocardial infarction, death of part of the muscle of the heart. It happens because of reduced blood due to a coronary artery blockage. The book goes into STEMI versus non-STEMI. I'm not going to get into that, but that's referring to the EKG where we talk about that ST elevation. So they can have a non-ST elevation heart attack or an ST elevation heart attack. A STEMI is a bad one, just real quickly, so that if you're reading a patient history and you see STEMI, that means that there was a complete occlusion or blockage of one or more of the coronary arteries, that it was boom, there is no blood flow to this part of the heart muscle, okay? So, and then you can see there's a picture on slide 28, kind of depicts a myocardial infarction. You see the left anterior descending coronary artery has a blood clot, and the blood clot is cutting off the blood flow, oxygenated blood flow to that part of the heart muscle, which is going to die, okay? And then 29 shows the coronary arteries, anterior and posterior view of the heart, okay? And then signs and symptoms of a heart attack, MI, sometimes crushing, vice-like pain that can radiate, referred pain, arm, shoulder, neck, jaw, back. Diaphoresis, dizziness or fainting, dyspnea, nausea, restlessness. It's almost like an underlying anxiety, like a feeling of impending doom. People tell me that all the time. Pallor, your patient will look like a vampire sucked the blood out of them. They'll be white as a ghost. And extreme exhaustion. A comedian described it as feeling like you're having to walk through pancake syrup, right? Everything is just harder. You're tired, you're exhausted, okay? With heart failure, you will hear an extra heart sound. So remember that S1, S2, lub, dub. Well, with heart failure, when they have an MI, you'll hear an S3 or an S4, and usually you will hear crackles, okay? Because that's the, pulmonary edema. And again, the quicker you get to the hospital, the prognosis is better, obviously. Never drive yourself, never. You always call 911 because your auntie down the street does not have advanced cardiac life support in her minivan. At least I don't think she does. So, she can't do anything for you while you're driving to the hospital. The paramedics can, okay? So you don't waste any time. Signs, symptoms, you get there immediately. Understand that with women now, used to be men were the #1 affected. It's women. The CAD and MI is the leading cause of death in women. And African American women are automatically exponentially higher risk because of things like diet and genetics, right? And women have a higher mortality rate. So in other words, if there were 10 men and 10 women that all had the same type of heart attack, more of those 10 women would die than the 10 men, okay? So, and usually it's because women will delay seeking treatment, right? They will have those atypical symptoms, so sometimes they're misdiagnosed completely. If they're complaining about GI problems and the doctor's working them up for a GI problem, but meanwhile it's a cardiac problem, that's time wasted. So make sure that you're aware of those atypical symptoms in women, okay? And so we talked about those atypical symptoms, like especially the heartburn, indigestion, epigastric pain, right? Those things are a problem. Make sure that any of the signs and symptoms of an impending heart attack, like shortness of breath, fatigue, heartbeats, that the rhythms are crazy or the rates are going up and down, up and down. Collateral circulation I will talk about very quickly. The older you are, believe it or not, the better your chance of survival. Why, you ask? Good question. Let me tell you why. When you are young, let's take two patients. We have a 40-year-old man and we have an 80-year-old man. Both of these people have coronary artery disease. The 80-year-old man, because he's older, his body will compensate, and the human body is amazing. I can't stress this enough. The heart will actually do its own bypass. It will develop collateral circulation, which means that little teeny tiny arterioles, little arteries, will actually form around the occlusion and provide at least some oxygenated blood to that part of the heart muscle that's being deprived of it. So the 80-year-old will have that collateral circulation. The 40-year-old won't. So if both of these guys start having the heart attack, guess who's probably not going to make it? The 40-year-old guy. Crazy, right? And when we're diagnosing, we're always looking at the patient's history. We're looking at cardiac enzymes and electrolytes. Make sure that you know that. And again, time is muscle. Can't say that enough. With nitro, you take your first dose. If the pain is unrelieved, call 911. You can still take the second and third dose. Okay. An adult aspirin. Start chewing on an aspirin right away. Right? Remember Mona. And then, I talked about all the interventions like oxygen and aspirin and morphine, et cetera, et cetera. Sometimes we need to intervene surgically, invasively. So percutaneous coronary intervention, PCI, like a balloon angioplasty, is basically where we're going in with a cardiac catheterization. And while we're in the coronary artery, we put, really it's a balloon. And when it expands the artery. And by expanding and opening the artery, it increases blood flow. Or we can put in a stent, which kind of looks like a mesh tube that we place into the artery that kind of holds the artery open and lets the blood get through. Okay? There's some pictures on slides 42, and 43 that show you kind of what stents and balloon angioplasty look like. Therapeutic interventions, daily weights, low sodium, low fat, low cholesterol. Stay away from caffeine because caffeine is a stimulant. Okay. Lose weight, stop smoking. I mean, I've said all this over and over again. And if you've done all these things or you haven't and things don't get any better, well, we may have to give you a cabbage. No, not the vegetable. Cabbage is coronary artery bypass graft. And what that means is that we're going to take a blood vessel from the leg, typically, and we're going to go into the chest, cut you open, crack open your ribs, saw open your sternum, rib spreaders, get to your heart, and we're going to graft that blood vessel that we took from your leg onto the coronary artery above the blockage, so that it's now going around the blocked area and feeding oxygenated blood to the part of the heart muscle that's not getting it. That is a bypass. So when people say, I had an open heart, ×2, what are they saying? They're saying they had a cabbage, right? And ×2 means 2 blood vessels were occluded. They can have a quadruple bypass, which means 4 blood vessels needed to be bypassed. And there's a nice little representation on slide 47 that shows you how we go in and graft that blood vessel to go around wherever the occlusion is. Okay? Let's see. There's some nursing diagnoses on the next slides that go through, for a patient with MI, what are the nursing diagnoses and what's the nursing care that you need to do. One of the things that I want you to keep in mind is depression occurs with patients that have a near-death experience. So patients will respond one of 2 ways. Either they'll be depressed with a near-death experience. Oh my God, I had a massive heart attack. Oh God, what am I going to do? Or they'll go the extreme opposite and they will be like, I got a second chance. I got a new lease on life. I'm living totally wrong. I got to start changing my life. And they'll have a good attitude. But you want to make sure, as a nurse, that you are evaluating how they're responding to the experience, because that's important in their recovery, okay? And we also can send them to cardiac rehabilitation, cardiac rehab, where they're basically going to a gym-like atmosphere, exercising, but they're exercising while they're on an EKG and monitoring their blood pressure, their heart rate, and their heart rhythm, okay? Okay. Next, we're going to talk about peripheral vascular disease, and this occurs in older adults and typically with diabetics. They're one of the ones that are notorious, okay? So peripheral vascular disease means that somehow, either arterially, there's not blood flow to the lower extremities, or from a venous standpoint, there's not blood return from the extremities. So it can be arterial, it can be venous, it can be both. Okay, which is double whammy. That's bad. So what are the reasons? Well, let's talk about some of the reasons for arterial blood flow occlusion. So there can be an arterial thrombosis or embolism. So in other words, a blood clot that's moving through arterial blood can then get stuck. Okay? These are usually the ones that come on, boom, very sudden, like a pulmonary embolism, right? They can happen in lower extremities or upper extremities. What happens is that clot, that thrombus, will get stuck to the wall of the artery, and especially if there's already like an issue with the arterial wall, and then it blocks off the blood flow. So with arterial blood flow occlusion, you're going to see, you go to palpate a pulse distal to where the occlusion is, you may or may not feel one, okay? So what are the causes of these things? Arrhythmias like AFib. AFib itself isn't a problem in and of itself, but the problem is the result of the fibrillation, which could be a clot, that then moves through circulation. So when we say arrhythmias, particularly it's AFib. A prosthetic heart valve, so a valve replacement that is either mechanical, made from titanium, which is a kind of metal, or even ones that are made from tissue, cardiac tissue from a pig, which is porcine, or a cow, which is bovine. Having a heart attack can be a cause. Or, believe it or not, when we talk about rheumatic heart disease, rheumatic fever, that can be a reason. So with an arterial thrombus, it's usually something sudden, and how bad blood flow is occluded depends on which artery the clot is in. If it's in a bigger artery and it's blocking off a large portion of blood flow, then the part of the body, let's say it's in the lower extremity can become ischemic because it's not getting blood flow, and then gangrenous. So gangrene can set in, and that is just, it's necrotic tissue that is infected. It looks black and hard and dead, and usually that requires an amputation, which is pretty significant. So remember your 6 P's when we're talking about clinical signs, okay? Pain, pallor, pulselessness, paresthesia, which is like pins and needles, paralysis, the inability to move that affected extremity, or poikilothermia, which is the change in the temperature of it, okay? And I'll explain that in one sec. And so with poikilothermia, we're talking about extreme changes in temperature. The term usually refers to animals that don't maintain body temperature, for example, like cold-blooded animals that their body temperature adjusts to their environment. But when we're using it in this context, it means that the affected extremity will have significant changes in temperature because of the occlusion, okay? And well, what do we do about it? Well, anticoagulants or a thrombolytic. We can do what's called a thrombectomy or embolectomy, which is a surgical removal. When you see ectomy at the end of a word, that is the surgical removal of whatever is at the beginning of the word. So a thrombectomy, removal of a thrombus, embolectomy, removal of an embolism, okay? And we talked enough, I think, about peripheral arterial disease. We know that, over time, there's going to be ischemia in that affected extremity, okay? There's a disease called Raynaud's disease. If you look at slide 61, it's spelled Reynaud, it's pronounced Raynaud's disease, and there is vasospasm with Raynaud's disease, typically in the distal extremities, and it usually starts in the hands. People with Raynaud's disease, their hands will be ice cold and blue. So there are spasms in the blood vessels that supply blood to the extremity, to the hands or the feet. And so when the blood vessels spasm, they tighten up, no blood flow, right? So because of that intermittent interruption of oxygenated blood, the hands typically, and the feet sometimes too, will again get really ice cold, blue, cyanotic, because of the lack of oxygenated blood. I had a patient in Florida that had Raynaud's disease. It would be 100 degrees, and he would have on 3 pairs of gloves because his hands were absolutely freezing. Let's see. So when we talk about signs and symptoms, sometimes they are insidious, like they creep up on you, okay? And sometimes they're sudden, but usually with arterial disease, they're sudden, but not always. And again, women tend to have symptoms that are not typical. Okay, in other words, symptoms that don't look like the disease, they're a little more complicated. But the extremity may hurt, so there can be pain, there can be muscle cramping. You will see hair loss around the extremity where it's affected. So in other words, if the lower extremity has peripheral arterial disease, below it, you'll see hair loss because of that lack of oxygenated blood. The skin will get super dry, flaky, scaly, okay? And toenails will get super thick because, again, they're being deprived of oxygenated blood. On slide 64, another term you need to be familiar with is intermittent claudication. And intermittent claudication means, intermittent means comes and goes. Claudication is a pain, right? So with peripheral arterial disease, patients will complain, when I walk, I'll get a pain in my legs. It'll come, it'll go, it'll come, it'll go. That is intermittent claudication, which is consistent with PAD. The skin will feel cool to the touch, cooler than the other extremity. If the leg is just hanging in a dependent position, in other words, the patient just say sitting, it will take on sometimes a reddish or purplish discoloration. And when the patient elevates it, it'll become very pale. and you'll either have a diminished pulse or totally absent pulse. So to diagnose it, what do? Most commonly is going to be a Doppler ultrasound, right? So they're going to do an ultrasound, and when they put that Doppler on the leg, they will be able to see on the screen where the occlusion is occurring, okay? There are other things that we can do like MRI or CT scan, but the most conservative as far as financially is concerned is the Doppler ultrasound, and they are very good diagnostically to diagnose PAD. What do we do to treat it? Well, what's the cause? So basically you're treating the cause. If it's high cholesterol that's causing the problem, we want to get them on a low-fat, low-cholesterol diet. We want them to lose weight. We may put them on a lipid-lowering agent like a statin, an antiplatelet like a clopidogrel or aspirin, or if we find it right away, a thrombolytic, a clot buster, okay? Those are non-invasive. Invasively, well, we can go in and do a PTCA, which is a percutaneous transluminal angioplasty, just like we talked about earlier. Same principle. We go into the actual blood vessel with a balloon, expand the balloon, and it opens up the blood vessel. We can put a stent in, or we can do a bypass. The same way we bypass your heart, we can do a bypass graft anywhere, even on the leg or the arm, okay? And there is a nice representation on slide 68 of an aortofemoral bypass. FYI, more than anything else, you're not going to get a question about that one, more than likely. Nursing diagnoses are on slide 69. And then on 70, Raynaud's disease. So it's those vasospasms that I talked about that constrict, relax, spasms of the blood vessels that cut off blood flow. Women usually more than men. It mainly affects the digits, in other words, fingers or toes. And you can have phases of the disease, in other words. So first it starts out where the hands or the feet will start to blanch. They'll get like a white color. Then they'll hurt. Then they'll get red. And then they'll go back to the blanching or bluish color. Okay, it goes back and forth. Basically, what do? Keep the extremities warm, and we're going to try to avoid vasoconstriction. And for example, nicotine is a vasoconstrictor, so don't smoke. Wear gloves, wear socks, protect the hands, protect the feet, and try to manage stress, because just like every other disease process that we're ever going to talk about, stress is always a contributing factor, okay? Moving right along, we are going to go to the next slide. We're going to talk about aneurysms real quick, which are bulgings or balloonings in a weakened artery. Most common is your AAA, abdominal aortic aneurysm, okay? And that is where the abdominal aorta, which is the biggest artery that comes from the heart and goes and feeds the lower part of the body, will have a bulging in it. And remember, it's under pressure. Arteries are under pressure because of the heart pumping the blood. And so over time, if we don't know that it's there, what's going to happen is it's going to balloon out bigger and bigger and bigger. If it ruptures, it's instant death, because basically your heart is pumping blood to nothing, to just the abdominal cavity. Usually we find these by accident, believe it or not. So the patient will go in, say, because they've got a bronchitis. And when the radiologist reads the chest x-ray, they'll say, yes, confirmed consolidation in the left lower lobe. And by the way, they have a AAA. And so that's kind of a godsend, because if we don't know it's there, then that's when the likelihood of it rupturing and the patient having, sudden death is increased. And the incidence of these aneurysms, by the way, increases with aging. All right. There are different types of aneurysms. We're not going to really worry about whether it's a fusiform or a saccular. There's something called an aortic dissection, which is basically a tear right down the wall of the artery. And it's the artery split kind of in half, and that's bad. That's usually sudden death, and there are some good representations of what they look like. Okay, with signs and symptoms, typically none with the AAA. Or when they do start having symptoms, it's usually as that aneurysm gets bigger and starts to put pressure, say, on nerves. They'll have back or flank pain, and your flank is your lower back area on both sides, right above the buttocks. Sometimes you'll be able to feel a pulsation in the abdomen, But usually it's nothing, and then pain, and then boom, rupture, which they will die from basically hypovolemic shock. Therapeutic interventions, we are going to watch that and monitor it, say usually every 6 months. If it gets to a certain size, we will go in and do what's called a AAA clipping or an aneurysm clipping, where we'll actually just have to clip off the aneurysm and suture it so that it doesn't rupture. Not going to get into varicose veins, but basically it is a dilated vein, causes unknown, the valves are usually bad, typically happens in the legs, and we did talk about this a little bit before, but just to kind of recap. So varicosities can be more superficial, so it's just like an aesthetics thing. You don't like the way they look. But if it's a big vein with a damaged valve that's dilated, then it can cause problems with, lack of venous return, blood flow back up to the heart, and that's when we would have to intervene. Okay, because stasis will occur. So in other words, wherever that varicosity is, it bulges because the valve is bad, and it'll just fill up with blood, and the blood will get stuck. Okay, people that are on their feet, not walking, but just standing, people like cashiers, those kinds of jobs that just stand for very long periods of time are most likely to get these. Pregnancy can cause them, and obesity. And when we talk about obesity, 20% higher weight than the recommended weight for your height, okay? All right. And I'm not going to beat the dead horse with varicosities. We have something else called venous insufficiency. That's chronic, and basically that means that it's kind of like varicosities, but it'll happen in multiple veins where there are damaged valves, and the aging process will cause pooling of blood. Blood will get stuck in the veins, usually in the lower extremities, and the blood can't get back up. People with these problems will present with edema, and then, over time, they can develop venous stasis ulcers, which look like a pressure ulcer, like a decubitus, except it's not over a bony prominence. They're usually at the lower extremity. So anywhere between the knee and the foot is typically where you'll find them. You'll see edema, you'll see hardened skin that almost has a leathery look to it because of that venous stasis. And again, the stasis ulcers can occur, and they're hard to heal, right? Because they're typically, because of that problem with venous return, it's just when blood sits, nothing's supposed to be still. Everything in your body's a one-way street, and it's supposed to be moving, okay? Therapeutic intervention. So if they have that edema, elevate, compression wraps, bed rest elevation. They should never stand for any prolonged periods of time. There is a treatment called an Una boot. We don't really see them used much anymore, but podiatrists love them. So they're kind of like a semi-cast that's put on the patient's extremity where the ulcer is. So it does two things. It provides compression, like a compression stocking would, but it's also kind of a medicated inner layer that is, helping to heal the stasis ulcer. And then the next slides have some nursing diagnoses and interventions for vascular diseases. And that is the end of this chapter. Woo! All right, guys. Till next time. See you. Peace out.